From Faith Forward Media, this is Healthcare Musings. I'm Dr. Hassaballa. Okay, everybody, we're going to talk about the A to F bundle. It's called the ICU Liberation Bundle, and it's a series of best practices that we should do for every patient so that we can liberate them from being in the ICU, right? So that's the whole point, is try to get them out of the ICU. And it's A through F, A, B, C, D, E, F. Okay, so the first part of the A to F bundle is A, which is assess, prevent, and manage pain. So obviously pain is an uncomfortable sensation. It's something that we don't want our patients to have. And if they're in pain and untreated, it causes physiologic and psychological stress. And so we definitely want to assess and then manage the pain. The way we assess, there are a number of scales that we can assess the pain. You have the numerical rating scale, which I remember when I had surgery, they kept berating me about the number after I had my thyroid surgery, and I just wanted a Tramadol, but they're like, well, what's the number? I don't know. Like, what's the number? What's the number? I'm like, okay, it's a 6. Just give me the pain pill, But that's where that came from. Right? They have to document what the pain scale number is, and I'm just giving a little insight as a patient. I just said 6 to get my pain pill. just give me my Tramadol. It's a 6. I don't know. It's very it's very subjective, right? It's very subjective, but that's where that comes from. So we do the CPAP, right, for people who are vented and sedated. We do the CPAP, or there's the behavioral, the posture of the smiley face and then the crying face. Whichever way we want to assess how much pain they're having, and then they also have bedside calculators that you can use, and then again. Then, if they have pain, there are interventions to prevent it, such as relaxation techniques, massage therapy. Which would be interesting if they had that. Pet therapy, we have pets that come through. Music therapy, I've been in hospitals where they have music therapy. It's really cool. Family presence for support and distraction. And then, if we have to give medications, IV opioids are the first line drugs for non-neuropathic pain. And then you can titrate them. It's interesting when it's very interesting, like a post-op cabbage patient, they don't have neuropathic pain. They have musculoskeletal pain, and we're giving them narcotics when really and ideally we should be giving them NSAIDs, right? Because it's muscular pain. And the problem with that, of course, is you have renal issues and bleeding issues, and so it's not easy. But I remember talking to a nephrologist who had a Bentyl. He himself had a Bentyl. He said Toradol was like manna from heaven. And I'm like, how did you not get renal failure? And he said, I drank the water out of the toilet bowl. I drank so much water to make sure that I flushed my kidneys so I didn't get kidney failure. He's a nephrologist. But we should think about what kind of pain. Is it neuropathic pain? There's one way to treat it. If it's musculoskeletal pain, there should be another way to treat it. And then first line for non-neuropathic pain are IV opioids. And we'll talk about that more when we get to the C part. So any questions about the A part? Assessing, managing pain. Okay. So now there's the B element, which is both. The B stands for both SAT and SBT. Spontaneous awakening trials, spontaneous breathing trials. The studies were done at the University of Chicago long time ago, where they interrupted sedation and analgesia every single day, woke up the patient up, respond to commands, move the arms and legs, and then they put the sedation down to the lowest, the least effective dose, and they found that those people got extubated faster and were on the ventilator less. Because before, we would just snow people at a RASS -5 for days and days and days, and it used to be benzos. Then you stop the benzos, and then they're still snowed for 2 more days because the benzos are now coming out of the fat tissue. And so there's another pump of benzos that are keeping them gone, and they're on the ventilator 5, 6, 7, 8 days. Now we don't do that, thankfully, because every day there should be a spontaneous awakening trial and a spontaneous breathing trial. Now, we have a patient with Legionnaire's disease who is 90% FiO2, 14 PEEP. We know we're not going to do a spontaneous breathing trial, right? The patient is clearly not ready for extubation. And we still should, ideally, if it's safe, do a spontaneous awakening trial. Interrupt sedation and see if they respond. what if they had a stroke? And I had a patient like that. I had a patient who was intubated. We kept the patient sedated for a long time, and we finally woke her up. Lo and behold, she didn't wake up, and she had a big stroke, like a big intracranial hemorrhage. That's scary, right? So even if we know we're not going to extubate someone, if it's safe, if it's feasible, if it's possible, we should do a spontaneous awakening trial, just to make sure that they're still there neurologically. We haven't found anything else. They can still respond to commands, and then when we sedate them again, because we know we're not going to extubate them, we go to the lowest effective dose to keep the RAS at target, whether it's 0 to -1, 0 to -2, 0 to 1, whatever that RAS target is. And the point is so that, because if you totally sedate them and completely keep them down, it really inhibits their ability to function and heal later when they're liberated from the critical care state, right? Where they've shown studies, and people have said they have cognitive issues. They can't balance their checkbook anymore. They can't think. They can't do things because of their hospital stay. And what we're trying to do is to make the patient as functional as possible after the ICU stay. We're all happy when they live. I am. I love it, right? And if they're alive and they can't function anymore, that's not good either, right? So that's the point of it's not only does it keep people on the ventilator less, but it also hopefully will prevent them from getting cognitive dysfunction, and then it'll allow us not to miss any devastating neurological issues. So even if we're not in, and then if they're eligible for a spontaneous breathing trial, we should try every day. We should try. We can't assume that they're not going to be able to be extubated. We have to try. And in units that have 24/7 coverage, like with 24/7 intensivists, there's no problem with extubating somebody at 3 in the morning, as long as the support is there, right? So there shouldn't be it's not during the day only. I mean, it depends on the ICU and your coverage, but I'm saying in general, as soon as somebody can be extubated, we should definitely extubate them. In fact, if we have a 0 reintubation rate, and let's say, I'm picking a number out of my head, 5-day duration of mechanical ventilation with a 0 reintubation rate, that's bad. I would rather have a duration of mechanical ventilation average of 3 days and a 10% reintubation rate. Because if we have 0 people who are reintubated and a relatively long duration of mechanical ventilation, we're not being aggressive enough. That we should accept I hate to use it, the price of reduced duration are some reintubations. You are going to have some reintubations. A 0, now, we are awesome here because we have a very relatively short duration and very, very low reintubation rate. We are amazing. A lot of units that I've been at, they have a very long duration of mechanical ventilation and 0 reintubations because they're not trying hard enough, right? We're the exception. We're fantastic here because we have a relatively short duration and very little reintubations. Most places are not as awesome as we are. And so you want to have, not that you want someone to be reintubated, but it's okay if some people get reintubated because that means we're really trying to get people extubated as fast as possible. And really every day, even if we know that someone's not going to be extubated because they're on such high FiO2, if it's safe. I mean, some people, if you wake them up and they start coughing and bucking, they desaturate to the 50s. That patient's not safe for a spontaneous awakening trial. And if feasible, every patient should have a spontaneous awakening trial every single day. Questions? So that's the B part of the ABCD. Now C, choice of analgesia and sedation based on the RAS score, right? So we use the RAS, the Richmond Agitation Sedation Scale. Some people use the RAS, the SAS, the Riker Sedation and Analgesia Scale. So there's a whole bunch of medications, fentanyl, morphine, hydromorphone, methadone, which we don't really use, remifentanil, which is a cousin of fentanyl, much shorter acting. That I tried to get here, and unfortunately, it's not available. So there's also other for non-opioid analgesia like acetaminophen, ketamine, gabapentin, lidocaine, the COX-1 NSAIDs. There's hypnosis and cybertherapy. Again, massage therapy, music therapy, cold therapy. Picking that sedative that will get you at target RAS with the least amount of delirium. And really, it's been shown again and again that benzodiazepines should not be your first choice. Now, in some people, it's the treatment of choice. So, for example, alcohol withdrawal, benzodiazepines is the first choice. It's the treatment of choice, right? Some people with methamphetamine toxicity or cocaine toxicity, bath salts, benzodiazepines, first choice, no question. To sedate somebody on a ventilator, benzodiazepines are not your first choice. And I see it so many times in so many hospitals across the country. They put them on propofol and they become hypotensive. So they say, oh, and they stop and they put them on Versadrip because they're not hypertensive. And it drives me crazy because propofol, you are expected to become hypertensive on propofol. It's not surprising. Propofol is a cardiotoxin. It can cause cardiotoxicity. It can cause hypotension. So can Precedex. So can dexmedetomidine. It annoys me to no end when people will then stop the propofol and put them on benzodiazepines, and then I come along and stop the benzodiazepines and put them on propofol. Benzodiazepines, again, a lot of them are lipophilic, so they sit in the fat tissue for a long time, and then you stop the benzo, and then for 2 more days they're out because it's now coming out of the lipid tissue, and they cause more delirium, and they keep people on the ventilator longer. They're just not good drugs. And they suppress respiratory drive. They are terrible drugs. I hate them with every fiber in my being. And I use them when they're indicated. But continuously, unless someone having seizure, status epilepticus, another one. Okay, benzodiazepines with continuous infusion are indicated. But just for really, your first choice either should be propofol or dexmedetomidine. My personal preference is propofol because people on decks wake up and they're awake and I don't know that I would want someone to remember being awake with a tube in their throat and the line in their neck and a Foley in their bladder and like this. So I prefer propofol. There's some research that maybe shows that Dex has a little bit less delirium. The data isn't the greatest. My personal preference is propofol. And then then ideally, if we can achieve what's called analogo sedation, meaning if I can achieve target RAS by treating the pain, and I can get to target RAS. So, for example, if we start a fentanyl infusion, for example, and we're at target RAS with just fentanyl, fantastic. That's the ideal, is to treat their pain with fentanyl, for example, and if that alone can get us to target RAS, phenomenal. And we don't have to put a sedative on, great. That's awesome. Many times we can't do that, right? They're still agitated. They're bucking the ventilator. They're still being desynchronous. So we have to add a sedative. And ideally, if we can achieve our target RAS with just fentanyl alone, or morphine or hydromorphone or whatever, that is the ideal. It's called analogo sedation. So if we could, that's why if you look in our vent bundle, fentanyl is always pre-checked first, and then the propofol have to check it later. Because if I can really try to achieve target RAS with just fentanyl, that would be great. Many times it's not possible, and that's fine. That's fine. Questions about that? You look like you want to ask a question. Oh, okay. Okay. So that's C. D. What do you think D is about? Delirium. Delirium. D is delirium. Assessing, preventing, and managing delirium. How do we measure delirium? Usually we use the CAM ICU, right? There are other assessment tools to measure delirium. Having delirium is not good for the patient. It does increase mortality. It can have long-term bad effects. So and sometimes delirium is not the patient that's agitated and needing 4-point restraints or wrist restraints. Sometimes they're hypoactive delirium. And if you listen, I've listened to radio stories about people who have delirium, and they're like, I was logging in the Pacific Northwest, and it was real. And if you could read the patient stories about delirium, I mean, it's real to them, right? We can't assess it, but it's real to them, whatever they're going through. So it's a really bad thing to have. Personally, I think a lot of delirium or delirium, a big element is sleep deprivation in the ICU, The monitor is ringing all the time. We're vitaling them every hour. We're getting there to assess them, neuro checks. God forbid any of us gets a neuro issue because waking you up every hour to do a neuro check. And the thing that sick people need is rest and sleep, and we don't give them in the ICU sleep or in the hospital in general. You don't get sleep, and I'm sure a lot of the delirium has to do with sleep deprivation. I mean, sleep deprivation is a torture technique, right? People do start hallucinating if they are, I mean, if they are sleep deprived. And Lord knows in med school, literally I was in the front row and I heard someone screaming because I was so sleep deprived. I had an auditory hallucination from sleep deprivation in med school. So sleep deprivation is a very bad thing, and I think it contributes to delirium. So we try as best we can to assess for it every day, and then try to minimize the effect as every day. So again, day is day, night is night, right? If they have, I think nicotine withdrawal is an underrepresented, underappreciated source of delirium. Somebody who smokes a pack a day and they come to the hospital and they can't smoke, yeah, they're going to be going crazy, right? We should definitely think about treating the nicotine addiction, making sure day is day and night is night. If they have hearing aids, to put their hearing aids in. If they have glasses, put their glasses on, right? So and try as best as possible to have them sleep. And all of these things, all of these interventions to try as best we can every single day, so that we can prevent delirium as best as possible. And hopefully, we're successful with that. And then if you really have agitation, we have, haloperidol and droperidol and Seroquel and all these medications that we do just to try to keep the patient safe. But that's really like the last choice. If we have to do it, Precedex. If we have to do it, we have to do it. Uh, Ideally, if we could try as best we can to minimize all the things that disrupt sleep, and so that we can minimize delirium, because having delirium in the unit is a very bad thing. Questions? Sometimes it can be lifelong. Yeah. Yeah, I mean, in the past we used to just take control of the patient and just do everything for the patient, paralyze them, deeply sedate them, and we're recognizing now that that is the worst thing for the patient. That we're really trying not only to beat the critical illness and have them survive, but we want them to survive and be a functional human being. So if they survive and they're completely useless, they can't do the things that we used to. Then what have we done, right? Yeah, they're alive. We're very happy they're alive. But if they're alive and they can't work anymore, and they can't do the things that they used to, and they're not happy. That's also something that's important for us to not just take over with them, but have them go back to where they were and be the person that they were before they got critically ill. And it's a tall challenge. I don't minimize the challenge of how difficult it is. Try to keep the patient safe. Try to keep the patient from desaturating to 50 when they cough, or when they turn, or they reach to try to pull the tube out, which can be life-threatening in a matter of moments, right? So there's a lot we're trying to do to keep the patient safe. I recognize that, and we have to do everything we can to make sure that they survive the critical illness intact as best as possible. And that's trying to prevent delirium as much as possible. Questions about that? What do you think E is? What was that? Evaluate. All of them were evaluate early mobility and exercise. So E is early mobility and exercise. So trying to get them mobile as much as possible. I know people, I've seen, the ICUs that walk ventilator patients. To me, if they can walk on a ventilator, we should just extubate them, right? That's how I feel. But sometimes you can't. Sometimes there's somebody waiting for a lung transplant, right? Sometimes they cannot come off the ventilator. Then yeah, that patient should be walked. I would love to at least try to get people in a sitting position in the bed as much as possible. That would be great. I know there are some machines that have like these cycle ergometers that they put people on ventilators for. I have to look at the data on that, but as much as possible, get people up, get people moving. Even if they're intubated, sitting in a seating position, spontaneous awakening trials every day. Try to get them extubated as soon as possible. Once they're extubated, up out of bed, into the chair. I mean, I after my thyroid surgery, literally first time I had lower back numbness for 6 months, and I wasn't even one day in the hospital, just sitting in that bed. But I had lower back numbness for a long, long time. took months to go away. So it's something that's super important for us to get up and mobile and exercise and try to get our patients up and moving ASAP, because the longer you just sit in the bed, the worse it is for you. No question about it. You get deconditioned, your muscles get weaker, and then you again, it's not a matter. It's surviving the critical illness, but you want them to survive and be functional. You don't want them to survive and be a functional quadriplegic, right? Yeah. Um, Paralytic medications and steroids, those two together, they can cause prolonged. Sometimes we have to paralyze our patients because otherwise they're going to die, right? But still, we have to keep in mind that sometimes they can cause prolonged muscle weakness, right? And then people are profoundly weak and deconditioned. So it's really important to try to get our patients up and moving as soon as possible. Post-op people and the vented patients. If we're walking somebody, I'd rather get them extubated. But if we can't extubate them, we should definitely be walking them or getting up in a chair or whatever like that. So questions about that? And then the last element is F, which what do you think is F for? Fun. We have fun in the ICU, but it's family. Family engagement, family empowerment. Family is fun. So making sure that we have patient and family centered care. Um, I love here. We always invite family to rounds every day. Families give insight into their loved one that we don't have. It's important that the families feel that they can see the whole team, that there's a whole team of people taking care of their loved one. Um, in the pandemic, when we barred families, it was really devastating for a lot of people, right? It was really devastating for a lot of patients. It's very lonely in the hospital. Even again, overnight after my thyroid surgery, it was super lonely in the hospital with nobody. And I can't even imagine these people during COVID. Remember, they're isolated, we're gowned up, we're all afraid in the beginning, right? And they have no family there. And how many people passed away with no family, right? So that was that I can't imagine how devastating that is. So that's why F is a very important part, and we should try to. Sometimes some family members can be difficult. Sometimes family members, sometimes can get in the way of care. We recognize that, and it behooves us to, as best as possible, try to engage with the families as much as possible. So because it is important to the patient's healing and health and well-being. All the problems with some families now notwithstanding. And that's it. And if we try to implement, and that's why our rounding tools have all of the elements of the A to F bundle to try to address it every single day on rounds, so that we're making sure that we're assessing pain, right? That we're doing our spontaneous awakening and breathing trial, that we're making sure we're picking the right sedation, we're making sure we're getting them up and moving, we're assessing for delirium. What's the CAM? Are they at target RAS? What are they CAM positive, CAM negative? The family, if they have any questions. That's the kind of thing that when you consistently implement all of the elements of the A to F bundle, you improve that process, you end up having better outcomes for the patients, which is the whole point, which is why we're here. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.